I'm Maya Henry. I'm actually a speech language pathologist by training and then decided to go into research. In my lab we study, we work with individuals who have Alzheimer's and also other types of dementia, but we work with types of dementia that don't manifest usually as a memory problem, so we become more sophisticated about studying dementia and learning that there are different flavors or types, and some of those people lose their ability to communicate, or they lose their ability to behave socially in kind of a normal social way. And so we study those other types, unusual types of dementia, and also interventions. So not drug treatments, but behavioral, so cognitive, linguistic, and other types of treatment to try to maximize a person's ability to function even in the face of neurological diseases.
My name is Dawn Guzman. I'm a graduate student in John's lab, and actually, much to the disappointment of John, even though I came in sort of interested in studying Alzheimer's and Down syndrome, and even worked for one summer for Bill Mobley, the guy that threw John under the bus about starting his research on Down syndrome. I actually ended up focusing on Parkinson's disease and also on my main focus is on alcohol-related research. But I have done a little bit of the Alzheimer's-related research in John's lab, and I also, as John mentioned earlier, our lab actually is many of our lab members have done the 23andMe testing, and I've taken a pretty big interest in how this can help people as a tool for understanding what their genetics can predict about their predisposition to diseases, and so I might be able to help with some of those questions.
Can I borrow that?
And Dawn's being too modest. She won a special education award from 23andMe. It's one of the first for her class that she taught ET students and adults with IDs. And she also does her alcohol research relates to a really interesting field called epigenetics, which I don't know, I didn't talk about it at all. But it's a fascinating topic, and I have a feeling that some of you asked questions that will relate to this. And Dawn has some pretty powerful research on that.
So, do you want to start with that?
Oh, start. Okay, let's see.
My glasses.
So here's a question that maybe relates a bit to what I was just talking about. What are the physical differences between Alzheimer's and other forms of dementia? So that's a great question. As I said, the clinical and research communities no longer see dementia as just one thing. It's not just Alzheimer's. There are many different types of dementia, and what we've begun to understand is that these are diseases, usually proteinopathies, so these proteins are misfolding and accumulating inside and outside of neurons. But the changes that we see in the person, the dementia, which is not the disease per se, reflects degradation of specific networks. So those might be memory networks in the context of Alzheimer's, speech and language networks in the patients that we work with who are slowly losing their ability to communicate, frontal networks that regulate behavior, and these may or may not occur with other kinds of changes like rotoric changes. So in terms of physical differences, I'm going to assume that that refers to in the brain, but the person who asked the question can certainly clarify or follow up with additional questions. So what we are learning when we use imaging, we can look at where the atrophy is in the brain. We can look at how that atrophy progresses or spreads, and we can look at changes in connections between different regions in the brain. So there are all kinds of different imaging tools that we can use to study how these problems manifest and how they change over time in conjunction with changes in behavior. And so, yes, we absolutely do see differences in how the brain changes in different types of dementia. And the topography or the geography of the atrophy makes sense relative to what we see behaviorally in the person. So as John pointed out, in Alzheimer's patients, we see changes in parts of the brain that are really critical for memory. We see early and prominent changes there. In the language-based dementias that I work with, so these are people who are in their 50s and 60s, start to have trouble with speaking and understanding language, and they eventually will become mute and develop a more global kind of dementia. But for many years, they're just losing their ability to communicate. When we look in their brains, we see left greater than right hemisphere changes. We know that for most people, the left hemisphere is the one that you use to communicate. And we see specific patterns that are predictive of the kinds of problems that they have. So, for example, if we see changes on the left side in the front of the brain, people have trouble articulating words or speaking in sentences. And if we see changes in more posterior parts of the brain, they lose their concepts and have trouble even understanding the words that other people are saying. So they look very, very different. And in some individuals so I'm talking about frontotemporal dementia here and different types of frontotemporal dementia, we can see changes at the very front of the brain, in the frontal lobes. People lose their sense of empathy, they lose the ability to connect and to interact socially with people. So these are people with a behavioral variant who often get psychiatric diagnoses early on. And so, yes, there are definite differences in the physical changes that underlie these different patterns of dementia that we see.
I'll go ahead and do another question here. Someone asked, so what is the statin controversy? How many people here take statins? Probably a good chunk. You're not alone. There's definitely over 20 million Americans taking statins. It's one of the big blockbuster drugs. And it really has made a huge difference. Statins are derived from a molecule that microbes came up with to kill other things, to prevent their cholesterol from being made. We've harnessed this as a trick to prevent our body from making more cholesterol. We certainly get a lot of cholesterol from our diet. We don't need our body to make more, is the idea. So most people taking statins don't experience any huge problems. They might have some muscle-related problems, but there's a small subset of people that do get transient memory problems. Their mind's in a fog. And this is real. I know personally, actually I know 2 doctors who've had this problem. I've met others that have this problem. We don't know the reason for this yet, but it's intriguing to think about the link between statin as a drug that can block cholesterol synthesis and ApoE4, which we know carries cholesterol around the body, and how that might be related. And unfortunately, I don't have an answer for you how that's linked, but all I know is that there is a subset of people that can get transient Alzheimer's from statins. Usually it's acute. So like in my mother's case, she started taking statins in the 90s. And it worked quite well for her to keep her cholesterol in check. I don't know if this statin use contributes to Alzheimer's risk long term. Maybe about 12, 15 years ago, people were thinking that statins might be a miracle drug to prevent Alzheimer's disease, but by now it is most definitely not the case. So unfortunately, that's not the answer. In this new era of personal genetics, we might begin to figure out, those with 1 or 2 copies of ApoE4 or other genetic, uniquenesses. Maybe it could be helpful for them or harmful for them. We don't. The verdict is out, but it is uncontroversially helpful in preventing heart problems, and that's a bigger cause of death than Alzheimer's disease right now. So pay attention to that first.
I don't know if I'm going to do a great job at answering this because it's actually not related to the genetics side of things. It's actually more sort of controversial related to 23andMe. The question is, do you have any concerns about what 23andMe will do with genetic/data security question, genetic data, or do the benefits outweigh the risks? as far as anyone can foresee. Are there any good companies, other companies worth trying? As far as I can tell, 23andMe is sort of like the big man on campus when it comes to the genetic testing companies, and in fact they have huge legal teams that are very careful about sort of data security and what they take care to let their customers know that they're keeping it as secure as possible. Really what has to happen, I think, is that legislation needs to catch up to protecting your genetic data, because I don't think there's anything really preventing, say, some government organization saying we need this person's genetic data. In fact, I think
Military, they're handed over.
Yeah, so I think 23andMe is doing its best to protect your information and keep things anonymized, and that they actually, as early as possible, remove names from their databases and just assign you a number so that, but then again, if you know something about this person's background, you might be able to kind of like, okay, this, the person's female from, maybe their age, their, other factors, you might be able to figure out if their data is that person's, but I mean, and then as far as the other companies go, I don't know much about how they handle data security, but I know that because of how long 23andMe has been around and how big and how much they've grown over the years, they kind of have to have a lot of safeguards in place and have a legal team to deal with these kinds of issues. And in my opinion, I mean, I thought it was worth it to do the testing, and I know a lot of people who have been satisfied with the information they've gotten out of it. So, do you have anything to add, Tom?
Yeah, well,
Yes, I mean, it's a tricky situation. It's trickier than you might think. As a scientist, I led into this thinking all knowledge is good, but it really did change context for a lot of things I didn't anticipate. So when you have a scary diagnosis, small problems in your family life can take on a totally new context. And that's something I was not prepared for. And that's something I don't think, even if someone were to tell you, you couldn't prepare for it unless you're directly experiencing it. So that's something I would take care of. 23andMe is a subsidiary of Google, something to keep note of. But they do, from what I understand, they keep the data in a network, in a bank that's not connected to a network. But just keep in mind we're living in this era of decreasing privacy.
Another 23andMe question there? I think there was.
is there another 23andMe question?
We can go on.
We'll come back. So, do you want to try something, Maya?
Sure. Let's see. Let's see if I can take this out. I don't have to keep passing that thing. Okay. Will people with neurological disorders, such as autism, have a higher chance of developing Alzheimer's? That is a hard question. I feel like
Not that I know of.
I'm in my dissertation exam or something. I'll talk about what I know, which is the advice that you're given for that sort of situation. So, not that I know of. One thing that it's not that neurological disorders and I'll say differences as well, because there's normal sort of variability that manifests from differences in the brain. It's not so much the case that neurological differences and disorders will predispose you to getting dementia, and I'll say dementia more broadly. Although there are certain things like traumatic brain injury that we know can actually, so repeated insults to the brain can actually give somebody a greater chance of developing dementia. But one of the things that's an active area of research is how people who have different sort of neural profiles may have a greater likelihood of developing certain types of dementia. So in these, what I'll call atypical dementias that aren't just memory problems, but other types of changes, we are learning that so people who have a lot of developmental language disorder or in their family or a history of developmental language disorder may, if they're going to develop dementia, be more likely to develop a language-based dementia. And so it's not that they're more likely to develop dementia, and I want to be careful to say that. Dyslexia is very common, and what I'm not saying is that if you have dyslexia, you're going to get dementia. But if you are going to get dementia and you had dyslexia, it may be the case that language networks in the brain are somehow morphologically different, more predisposed or vulnerable to whatever pathological process is causing dementia. And that's something that we have a lot more to learn about.
I'll try something. Someone asked, is there any research on the effects of volatile organic compounds on the brain, pains, glues, gases, and what occupations are the highest rates of Alzheimer's disease? There is research on, that I'm aware of, on the number of times someone's experienced anesthesia in Alzheimer's disease, which is mysterious. And I really don't have any, I don't think anyone has any good idea why that might raise the risk ever so slightly. But it looks like it might be real. But again, it's also not big. So this isn't to say that you shouldn't have surgery. I mean, no one is changing whether or not they have surgery based on this minuscule risk. But it relates to this question, what environmental factors might contribute to Alzheimer's. In Parkinson's disease, there are definitely environmental factors. In fact, there's certain toxins or pesticides that we know, or drugs that we know can kill dopamine neurons in the brain. So there is a mystery there. What occupation is the highest rates of Alzheimer's disease? I don't know the answer for highest rate. I know for lower rate. For lower rate, the higher educational attainment you have seems to delay the age of onset of Alzheimer's disease. And the best hypothesis around this is that they might have, through education experience, and maybe just thinking harder, maybe using different networks of the brain, like showing up in a lot of brain matters event like this, all just lowered your risk of Alzheimer's disease by 1%. So, well, that's for you. But you can think about it. So if you have more experience, you might be able to, you might have memory problems, but you also be able to figure out ways around that. I think that's the simplest idea for now. But these are all, these are good questions.
Look at you. I'll give you one. I mean, here, take a guess.
Okay. The question is, would you recommend participating in trial studies for Alzheimer's? Yes. It really comes down to, in any clinical trials, I think it comes down to, are you comfortable with, anytime you take a medication that hasn't been tested, there are some potential side effects, and there's no guarantee it's going to work. And an important thing that maybe not everyone thinks about before they participate in trials, you may not be getting the drug, you may be getting a placebo. So you have to, even though it might help future research, this drug, even if it is effective, you might not be put on it if you are participating in a clinical trial. But as a scientist, I'm going to say absolutely, yes, you should participate in clinical trials because we need all the help we can get from you. I mean, if you have a family history of Alzheimer's, or if you are concerned about getting, or even if you don't, that's also important. We need people who are sort of controls for these experiments to understand what contributing factors we need to study to understand Alzheimer's better.
Someone's asking if you can remove the APOE4 gene with kind of modern technologies called, like, for instance, one called CRISPR. You need your APOE gene. You don't want to completely remove it. So the trick will be not removing it, but replacing it with a different one. Someone asked if this is the so-called, replace it with the so-called APOE3 version, the wild type one. Wild type is a special word. That means what's commonly found in all of us. And I hate to say that APOE4 is a wild type version. We all have, and it could, at least to me right now, it's not doing anything terrible that I'm not, aware of. I was able to reproduce, have 3 kids, teach at UT, get tenure, all the critical things in life. But yeah, one I talked about, usually when you think about drugs, you think about taking a drug that's essentially a tiny molecule that fits exactly onto a pathogen or a faulty molecule to immobilize it. We're now entering the era of genetic medicine, where you can edit your genes. And it's a pretty exciting field. It's just in its infancy right now, but we are in theory able pretty soon, within the next decade or two, to come up with the first medicines that could go in and replace a faulty gene with a safe one. I don't expect that ApoE4 will be on that list as the first genes to be treated.
No, actually, I think it's one of the couple being discussed.
Yeah, but they'll reach clinical trial because the first genes that will be affected are those that will cause will kill you as a child or give you muscular dystrophy, or these are the first diseases that people are working on for genetic modification. It's definitely something to keep your eyes out for in the news.
And actually,
Go ahead.
really quickly, they actually discussed Alzheimer's disease specifically, and I wanted to say it was a Radiolab podcast. So if you guys are interested in listening to podcasts, I believe there's actually a CRISPR related one a year ago, and they do discuss the sort of ethics behind, if we can edit our genes. First of all, I mean, people go kind of far, science fiction-y and go, oh, what about people will be able to just pick the color of their children's eyes, or give us a movie Gattaca talking about designer babies and selecting, and only the rich can select these perfect genes for their babies. But they also talk about the idea of if we know that something like ApoE4 really significantly can increase your chances of getting Alzheimer's or lower the age of getting Alzheimer's, what if we could just completely remove it from the population by anyone who has it? We'll just replace it with ApoE3, and it won't be in the gene pool anymore, theoretically. I mean, I'm sure someone will still have it, but yeah, that's great. It was a really informative podcast that you guys might be interested in.
Okay, we have a couple of questions about biomarkers and imaging, so maybe I'll take those on together. So is there a diagnostic test for plaques, the beta amyloid plaques? Plaques and tangles are the pathological markers in Alzheimer's. And the answer is we've come a long way, especially in Alzheimer's, at developing in vivo biomarkers. So we used to say that you could never have a definitive diagnosis of dementia until autopsy, when you could actually take slices of brain and use special stains to look for these pathological entities. Now we have different types of scans that we can do to show us different things. Most commonly, people just get an MRI scan, and that shows us gross changes. So the shrinkage in the brain, the atrophy that takes place when the diseases progress to a certain degree. But what you can't see are the microscopic changes happening at the level of neurons. But now we have different types of scans, PET scans, that can detect things like plaques and tau even now, more recently. That's very encouraging, and they're not sort of standard of care yet, but I think increasingly are being recognized as an important contributor to differential diagnosis in dementia, and are being used a lot in research to do that sort of thing, to think about candidacy for clinical trials even. A related question has to do with, so do you agree with the objective classification of Alzheimer's and we'll say other dementias based on biomarkers compared to other things like imaging and neuropsychiatric or neuropsychological or neurological evaluation, I'll say. So I won't say that I agree or disagree. I think that these are all important tools. I don't ever see us moving away from the neurological exam and neuropsychological assessment and getting a careful patient history to learn about the onset and progression of symptoms. Those are always going to be important factors in diagnosis, whether we're thinking about standard clinical care or assigning someone to a specific drug regimen. But increasingly, these tools, these imaging tools that allow us to see what's going on in the brain in life they are increasingly important. Doing a spinal tap and getting cerebrospinal fluid and looking at levels of things like tau and amyloid in the brain are becoming increasingly more important as contributing pieces of information. So I don't think it's a matter of saying one or the other. And I'm a believer that carefully looking at the phenotype or the behaviors that we can see when we look at the patient, when we sit across the table and do cognitive assessments and other types of assessments are equally informative in terms of thinking about the big picture. So I don't think it's ever going to be a matter of one or the other, but all of the above.
Yeah, my mother, for instance, she wasn't able to read. That was one of the first things to go, and she eventually did get an MRI, and they saw a small millimeter-sized hole right in the area you would expect reading to be important. So it turns out she didn't need an MRI for anyone to tell her that said they work with someone like mine, they'd be able to work with you and kind of deduce this. I'll try to answer we have a lot of questions here that relate to one another. A lot of them are, your loved one or yourself are having problems remembering names. What does that mean? I have Alzheimer's disease or not? It's just like when I talk to my father. Remembering names is one thing. For being able to remember how to work the microwave or the oven, being able to put together a recipe, something that takes multiple steps. That's a sign that you should definitely talk to your doctor, your neurologist. If you're ever worrying that you have family history and you're worried that you yourself might be at risk for Alzheimer's disease, I would encourage you to go to the Alzheimer's Association. They have a kind of a 10 risk factors that kind of look. I'm sorry, not risk factors. The 10 different checklists. See, I'm forgetting where you're. Checklist. So, see how many. Reassure yourself that it's only names or certain words that you're forgetting, and it's not other things down on that list. Become familiar with what's on that list and what the progression typically is, and I think you'll realize that it could be something as simple as stress in your life, or problems with sleep, or travel that's interfering with your memory, and it's not bona fide Alzheimer's disease. So if you do have a history of Alzheimer's disease in your family, become familiar with this checklist. Some people are asking about other risk factors like smoking. Now we're in the era where I think everyone understands smoking can be bad for other things. Smoking can be bad for Alzheimer's too, in particular, especially with the cardiovascular link there. Other people are wondering about sleep. Is sleeping 4 hours at a time if you can't sleep through it? Yeah, anything's good. I think if you're to read that book, which is emblematic of other books, they're going to say there's 30 or so things that you could do to decrease your risk of developing Alzheimer's disease, or at least put it off for a longer period of time. And anything you can do to help that would be great. And again, unfortunately, a lot of this has to do with your behavior. You have to not eat that cake, or go to bed at a reasonable time, or this is much harder than popping a pill. But if you can work with your family and friends and form a team to get this. One of you asked about time-restricted feeding. Dieting can be really hard for everyone. My mother was a dietitian, and it's hard to change behavior because there are these circuits in our brain become hardwired to do the same thing over and over again. One trick you can do to keep it simple is just eat only within an 8-hour period. Don't eat until 11 o'clock. Once it's 7 o'clock, tell your friends I'm not eating. I don't eat after 7. That's just me. You can eat, but I'm not going to have that snack. Just doing this, you're going to find that you don't even necessarily, as a first step, you might not even need to change your diet. You just will be eating less because you're not going to be snacking at night anymore. It's going to make like I guarantee if you do this, you will probably lose weight, like 10 pounds or so. It's pretty impressive, just a simple behavioral trick like this. And it's easy to remember. You see, that's me. I just eat during this time. The liver connection. The liver in the detoxifies all sorts of molecules throughout our body. Without the liver, we die because they accumulate. Our brain is a complicated organ that is chock full of these things, and it has to be drained through our bloodstream and detoxified through the liver. If you're trying to talk to your loved one who might have a drinking problem that's affecting their liver, their liver is spending all the time detoxifying alcohol, that's less resources for that's less that your liver can do to detoxify problems from your brain. So this is something to think about here. So that, I think I tried to cover a lot of things.
Well done. I wanted to comment on the not being able to remember words. Whenever I talk to people in the public about the disorders that I study, where word finding is a prominent early symptom, people always come up to me afterward and say, I have that problem. And I will tell you, everybody in this room has that problem. Some of us only have it when we're tired or stressed, but as we get older, everyone has more and more trouble finding words. It's a pervasive feature of aging. The good news is, though, that your conceptual knowledge, your concepts about things and people in the world, it's one of your cognitive abilities that continues to grow and grow and grow with aging. You're always getting smarter. And your vocabulary continues to grow and grow and grow with aging. The problem is with accessing those words when you need them, and words that you use less frequently are always going to be harder to find. So retrieving the name of your son or daughter is going to always be easier than retrieving the name of someone you only see every 6 months. And that's true for all vocabulary, not just for names of people. So thinking about when should you get worried, you should get worried if you're not remembering the names of people that you see all the time, or not remembering the names for the objects that you interact with every day. And in general, thinking about the kinds of cognitive changes that you should be concerned about, just to add on to what John already said, which I fully agree with. Anytime changes are becoming disabling, they're limiting your ability to function in the world the way that you need to accomplish everyday tasks. That's when I think there's a concern that would warrant talking to your doctor or going to see a neurologist, even if it's just to put your mind at ease. But certainly our brains change with age. It's one of the things that we all face. Word finding, we all have trouble with that. And we all slow down a bit. So processing speed, we have sensory changes in vision and hearing that affect our ability to interact with the world and to operate kind of as quickly and efficiently as we would like to. And that's part of normal, healthy aging.
Okay, I think we answered most of the questions. I have to run up to the prom. So I apologize. It's 5 o'clock. I'm going to have to take off. If you want to ask Don and Maya questions informally after, I think that's okay. But I'd like to thank all of you once again for coming to attend. I invite you to come back next month to hear Dr. McKenzie talk about epilepsy, totally different topic, just as exciting. And yeah, thank you for coming.